Greeting everybody. I'm really honored and happy to participate in this stroke conference. I'm Dr. Nabeel Hameed. I come from Kingdom of Bahrain. I work as a neurosurgeon in Salmania Medical Center, and we face a lot of cases of strokes, which we need to manage with a decompression. Hence, I'm presenting this short and small presentation regarding the role of neurosurgery, i.e. craniectomy in ischemic stroke. And I'll be concentrating mainly on malignant MCA infarct or malignant MCA strokes, because these are the dilemmas actually, or our pathology is giving us the dilemma whether to choose surgery or not. What's the need for the decompression craniectomy? And I find this quote a very small and beautiful quote in the German literature, which says in a patient with a large space-occupying infarct, the subsequent edema complicated by transitional herniation possesses a lethal threat, which is basically the high mortality of this type of disease. We know that the mortality on medical treatment only with large ischemic strokes is nearly 80%. So there has to be another solution, and surgery in the form of decompressive craniectomy could be the solution for this dilemma. Just to exemplify the need of decompressive craniectomy, I present this small case. A few months ago, a 57-year-old male presented with, as you see, in vision or in figure 1. I don't have a marker to mark there, but in figure 1, you'll see that right MCA infarct frontotemporal, a large one, which have progressed later on at the end of the day to a very large, much clearer infarct with midline shift in image 2. That's about 12 hours after the presentation. Patient started to deteriorate with starting to lose consciousness. The symptoms were more aggravated. A CT scan was repeated showing the subfalcine herniation. You see the deformation of the frontal horn, indicating a massive edema there. What was done was an immediate decompressive craniectomy, and this image number 3 was 24 hours after the decompression. You see already some sign of effect of the decompression has taken place. Most of the brain was allowed to herniate a little bit outside the skull, so there's a little bit of correction of midline shift. And 1 week or 8 days after the decompressive craniectomy, you see nearly the midline shift has corrected completely with the effacement of the ventricle corrected. This patient was discharged after 3 months. Still has a very grave deficit, but he's alive and at home. This just exemplifies sometimes the need of decompressive craniectomies in these type of patients. Who will benefit from decompressive craniectomies? We can basically stratify them or classify them in certain groups, but the main group is definitely the infarction group or the stroke groups, which could be allied cerebellar infarcts, which I'm not really, I won't discuss in this presentation because they have much better, clearer pathway of treatment, surgically speaking. We tend to be more liberal in decompressing them. We tend to be more liberal in putting spinal-vertical drain for them, and relatively they do better. The data still doesn't support a very clear surgical treatment for them, when and how, but it's much clearer than the malignant MCAs. Of course, the other group and the larger group and the more difficult group to handle is definitely the patient with large infarcts or middle cerebral artery infarcts, and this is what I'll deal with them today. Of course, the post-TPA, post-embolectomies bleed. I won't deal with that because we have very bad experience with them here in Bahrain. Still a progressing, still in infancy, I think, all the data collection with regards to them, because the large numbers are not corrected yet. So I'll deal basically with malignant middle cerebral artery infarcts. How do we define this type of infarct? It's basically a brain ischemia or brain stroke, which is large enough to cause shift in the ICP, to cause problems in the ICP with the potential to herniate and thus clinical degradation. So it's not all patients who will present with cerebral or malignant MCAs, and there are certain predicting factors which could predict that this patient will degrade and have a malignant MCA. It's only, some studies will say it's only 1 to 10% of all middle cerebral infarctions or middle cerebral artery infarction will progress, and I found this article which puts it at nearly 19% patients with strokes would progress to middle cerebral artery occlusions or malignant MCAs. This article also puts certain clinical and neurological predictors from whom these patients will progress. Basically, a higher stroke score they tend to progress more. Female also tend to have more incidence of occlusion, of MCA infarctions or malignant infarctions. High blood pressure and congestive heart failure are also associated with high incidence of malignant MCAs, and young age. The young age most probably because of in older age you'll have a little bit of cerebral atrophy. The tolerance, ICP autoregulation may be more tolerant, plus you have the collaterals due to atherosclerosis, vascular collaterals, which are not there in young age, for most probably that's why they're more predisposed to malignant MCAs. Some of the neuroradiological predictors for this is, of course, the CT scan, which is the most predictive, and anything more than 50% of ischemia in the corresponding territory of the MCA is a strong predictor, and then actually a very strong predictor of malignant MCAs. Some other studies, measurement of optic nerve sheath, which indicates the ICPs, could also be as an indicator. If you do a CT angio with signs of poor intracranial collaterals, that also is an indicator. And if you do an MRI with DWI sequencing, infarct volume of more than 145 cc is a strong indicator of bad prediction. Prognosis of patients with MCA or malignant MCA is really poor, as I mentioned in the beginning, with nearly 80% mortality if only treated conservatively, hence the need for other methods of saving these patients, and the decompressive craniectomy. What do we do with the decompressive craniectomy? As the figure, this is of course for non-surgeons, you see that it's not a complete hemi-craniectomy, but we take big part of the vault out. That's the frontal, parietal, part of the, most importantly, actually part of the temporal going down, temporal bone going down. We do a very big flap, and then we open the dura to allow the brain to herniate outside, thus decreasing the ICB, thus decreasing further damage to the brain tissue. This procedure is not new, and it's been done for the last 100 years, more for trauma, tumors, and these things. But in the recent advances of stroke treatments with TPA or thrombectomies, this procedure again has taken stride in saving those patients or selective patients who do not benefit from those type of treatments. Do we have evidence for this? That's the main question actually, and that's the main topic of my talk. The evidence is very scarce, very contradictory. Certain studies will say yes, certain studies there's no benefit. Certain studies will say no, it's beneficial. So I'll try to just illustrate some of these studies in the hope that we come to a certain conclusion. These are some of the studies that I wanted to show. All of them are RCTs, all of them are randomized trials. And I'm sure that most of you have heard of them. They start with Decemel, Destiny, and they're mainly, sometimes they're done in each country. For example, the first study, which is the Decemel, it's done in France, and it included nearly 38 patients, so an average age 18 to 55. The inclusion criteria was basically a stock score of more than 15, or if there is a deterioration of more than 1 point in the consciousness level. And the imaging criteria was basically if there is a ischemia more than 50% of the MCA territories, and if an MRI was done and the WDI infarct showed more than 145 cc's. It's done less than 24 hours of the onset of symptoms, and the primary outcome parameters at 6 months was basically a modified Ratling scores of 0 to 3. The findings were mainly on mortality, which was significant, and there was an absolute results of 52.5 reduction in mortality for decompressive group, which compared to the medical managed group. But when it comes to modified Ratling scale, at 6 months, there's no significant difference between the two groups. I don't want to go into the gritty of each number, but this is what the summary of this study says. The other studies, for example, Destiny 1, which was done in, I think, Germany, was inclusive of 32 patients. The age was 18 to 60 of age, or years of age, and the inclusion time was 12 to 36 hours. Less than 36 hours, more than 12 hours. The inclusion criteria or image criteria was 2/3 of the MCA territory was involved, with or without the partial or complete basal ganglia, with other territories like the ACA or the PCA territories, whether they're involved or not. And their strokes scoring was always more than 18 when a non-dominant hemisphere, and on the left side it's more than 20. Because most of the studies have shown that definitely the mortality will decrease with the decompressive group, they did a sequential design of this study. So they judged the mortality over 30 days, and then when they survive after 30 days, they scored the modified Ratling score from 0 to 3 with the 4 to 6 at 6 months. And there was definitely a mortality reduction from 88% in the DC groups to 47% in the medically managed groups at 30 days, which is definitely significant. but there was no primary effect or outcome in the outcome score. Most of these patients still ended up actually with a modified Rand score more than 4. Other studies, which is Hamlet, which was, I think, the Dutch studies, nearly came to the same conclusion with that decompressive craniectomy has no effect on primary outcomes, but significant reduction in fatality and mortality. There was also a Chinese study of the Zhao et al., sorry for my pronunciation, which included patients who came with symptoms up to 48 hours, and the age was extended up to 80 years. The inclusion criteria, radiological criteria were nearly the same, but the clinical criteria, they used a glaucoma scale of less than 9. I think this study was stopped after 24 patients were included. And after the 24, they stopped it because they found that there is a significant difference of mortality between the two groups, and ethically they couldn't do it. They couldn't continue with the study. So there was a significant mortality favoring the reduction in mortality favoring the DC group, but the outcome in these 24 patients after 6 months with the modified Ransom scale is the same. The same thing was showed by the American study, which was done and included about 24 patients, which shows there is no significant reduction in the mortality at 21 days. And there is no significant actually outcome after 6 months in regard to modified Rankin scales. To have a selected group of more than 60 years of age, Destiny 2 was again done in Germany. Again, the same result, the significant reduction in mortality, but there is also a significant reduction of severe disability, which is modified Rankin scale OMRS of 5 to 6 also, but this is really subjective because a modified Rankin scale of 4 and above is an indicator of disability. There was a Chinese study, and there was another, I don't know, the Filipino study, I think, after that. Most of them came to the same conclusion. The meta-analysis was also done because individual studies fall short of giving a conclusion. So meta-analysis was done, one European one, which have included the Hamlet, the Decimal, and the Destiny studies. And patients from 18 to 60 years old were included, and both the modified Rankin scale at 1 year or 6 months and 1 year was looked at, and fatality and mortality at 1 year was looked at. 93 patients were included and analyzed, with 51 patients randomized to the decompressive group and 42 patients was randomized to the conservative treatment. As was shown in the individual studies before, there is a significant decrease in the mortality. A Cochrane review also was done for the 3 European trials, and it included 134 patients, again, 60 years old and younger. And the conservative group the DC group showed a significant reduction in the risk of death and mortality for the DC, or favoring the DC group. Another meta-analysis, a bigger one, I think this is much more recent. I'm not really sure. I think it's about 2017. 338 patients were done, with 165 patients allocated to the DC group and 173 patients allocated to the conservative group or medical group. With regard to mortality, there's definitely significant reduction in the DC group. As we see, most of these meta-analysis and most of the individual studies show a decrease in mortality. There is a discrepancy in showing the improvement of outcome at 6 months or 1 year. Some of the studies show, yeah, there is, and some of the studies shows there is no improvement. We have to take this with a little bit pinch of salt, because as you see, most of these studies actually, and as I mentioned before, has defined a good outcome above 4, which is in the modified outcome scale is actually a bad outcome. Some of these patients will do come with a bad deficit. So one of the biggest dilemmas in decompressive cranectomy is actually the timing, because we fall in this every day when we see a stroke patient, because we don't know what to do, like to do it preemptively and risk doing a procedure which is not needed, or shall we delay it for deterioration and risk some neural damage, more neural tissue damage. So it's still very, very difficult to choose. Some of the literature which I dug or dealt with this, and one of the good articles was published in the Journal of Stroke 2017, which took 1,301 patients and divided them into patients who undergone DCs at 24 hours, 48 hours, and then 72 hours. Both, when they grouped together or separated, showed a significant difference. However, in a continuous analysis, later DCs or delayed DCs showed that greater odds of discharging these patients to institutional care means they do need care. So the earlier you do decompressive cranectomy has a better outcome. But again, mainly on mortality. Another study, which was done more specifically, which is, regarding time, which is less than 6 hours, and this is like nearly a preemptive surgery, took 46 consecutive patients. 27 patients were allocated to surgery after clinical deterioration, which was proven radiologically, and 19 patients went into ultra early surgery, which is less than 6 hours. There's no significant reduction or mortality favoring the ultra. There's no difference between the two. And furthermore, the author reported that statistically a significant improvement of the functional outcome of the ultra group was not that much. This puts us, it's a little bit difficult to decide whether, there's not much of evidence supporting when to take this patient. But as general rule, which was also shown by all the studies I showed in the table, that some of the patients were grouped with more than 12 hours, some of the patients were up to 96 hours. As we know that the significant edema post-infarction will come within the 48-hour window after the infarction. It was presumed that anything below 48 hours will be safer and better, with better outcome. But this is also left to individual institutions and what medical support, medical type of treatment they provide. There is definitely an ethical consideration for doing or not doing decompressive cranectomy. And this is not addressed enough, I think, in most of our practice. There is definitely a very good evidence that we'll be saving lives with decompressive cranectomy. And actually, this is one of the points that I discussed with the family when I opt for doing a decompressive cranectomy, and I tell them I'm saving lives. The function comes later. Let's let this patient be alive, and then we'll see the function later. But is it a proper approach or not? This has to be ethically discussed and addressed, because most of these patients, do they survive? They will definitely survive with a disability. And as we showed in the 3 European RCTs, that most of the patients will survive with a disability. Very few will come out. The decision-making skill is a challenge. As the survival here could be, the cost of disability. And this sometimes is not acceptable to either the patients or the family, and this has to be discussed. There's also another facet to this, which is the economic and resource load over the hospitals and individuals. Because if we're more aggressive with DCs, then you're producing a lot of vegetative and disabled patients, which will need chronic care and long stays in the hospital. And this puts a significant economic and resources load on all the hospitals. In conclusion, I feel that malignant cerebral infarction is a life-threatening condition with a high mortality rate, and the only option as surgeons are given if the medical treatment fails is the surgical option, which is i.e. the decompressive craniectomy. And we do have some randomized trial studies on that, favoring the survival, but not the disability point of view. We know definitely that the decompressive craniectomy reduces the mortality rate in these patients, however, leaving the majority of patients with at least one disability. So before the surgical standard intervention, we recommend careful assessment of the patient, not only the patient, also the institution, because if you're capable, these patients will definitely need high-end ICUs after the decompressive craniectomies. They need a lot of care, physical rehabilitation, cognitive rehabilitation, OR, these things. And if it's not available, this definitely affects the long outcome. Thank you very much. I hope it's a big topic, and it's a very controversial topic, but I hope I just shed some light on it. Thank you very much.